We see these things happen all the time in Medicare Advantage. People waiting for surgeries, people being forced out of the hospital before they're really well, people not being able to access subacute rehab after a stroke or other injury. These problems occur in Medicare Advantage at an extraordinary rate, especially compared to traditional Medicare.
911, what's your emergency?
America's healthcare system is broken and people are dying.
Welcome to Code WACK, where we shine a light on America's callous healthcare system, how it hurts us, and what we can do about it. I'm your host, Brenda Gazar. This time on Code WACK, Privatized Medicare now covers more than half of older adults nationwide. But how do Medicare Advantage plans, lower star ratings, narrow networks, and paper benefits hit seniors of color hardest? And why are hospitals dropping these plans, leaving patients in the lurch? Our guest is Dr. Belinda McIntosh, an Atlanta-based psychiatrist, Physicians for a National Health Program board member, and co-author of the PNHP report, No Real Choices, How Medicare Advantage Fails Seniors of Color. This is part 2 of a 2-part series. Welcome back to Code WACK, Dr. McIntosh. When we say that Medicare Advantage plans enrolling more Black, Hispanic, and Asian seniors tend to have lower star ratings, what does that mean for patients? And what does lower quality look like when you're sick, older, or disabled?
Okay, yeah, that's a great question. So the star rating system is something that CMS, the Center for Medicaid Services, which that's who's over Medicare and Medicaid, they developed this star rating tool so that patients could be able to see the differences between plans as they're choosing them. And so a plan with a high star rating versus a plan with a low star rating will differ on things like how long it takes to process a prior authorization, but also things like quality of care. So how often are people getting the care that's considered standard for chronic conditions like diabetes or high blood pressure or other cardiovascular issues? How long do people stay in the plan, or are people switching out of this plan often? How robust is the network? So a lot of these things will factor into a plan's star quality rating. And the thing is, if the plan has a high star rating, they get a bonus from CMS. And so there is this way that plans that are in areas with, kind of less healthcare spending because they're healthier communities, which often in our country means wealthier communities that may be whiter than other communities. They have less healthcare spending overall, and they will get bonus dollars from CMS. And they can then pass those bonus dollars on to their enrollees in terms of giving them supplemental benefits or lower premiums and other kinds of, advantages. And when that happens, this continually boosts their star rating. And so there's this compounding effect where that then continues to shunt CMS dollars towards wealthier, wider communities.
Wow.
The structural inequities are so built into the system.
So in the PNHP report, you document how prior authorization and narrow networks hit seniors of color especially hard. Can you give us an example of how those barriers delay or deny care in ways that seriously affect health outcomes?
Okay, so let's talk about narrow networks, right? So when people are limited in terms of their healthcare choices based on income, they're going to have fewer choices. And what we're seeing across the country are that hospitals in rural areas and hospitals in low-income areas and hospitals that serve predominantly people of color close at higher rates. And a lot of that is due to lack of reimbursement. And lack of reimbursement is directly tied to insurance barriers. So when there's a prior authorization that's denied or for a medication that a patient can no longer take, which was keeping them healthy, they can experience a negative outcome. When their hospital stay is not approved or their surgery is not approved or their surgery is delayed for 2 or 3 months waiting for approval from the insurance company, that's also going to result in more harms, negative outcomes, delays in care. And so we see these things happen all the time in Medicare Advantage. People waiting for surgery surgeries, people being forced out of the hospital before they're really well, people not being able to access subacute rehab, after a stroke or other injury, so they don't get back to their level of functioning. These problems occur in Medicare Advantage at an extraordinary rate, especially compared to traditional Medicare. The point is, if you know you're going to one day become ill, debilitated, you're going to want a health plan that is going to take care of you when you're at your sickest. People who are in fair to poor health, who are accessing more care, they fare worse in Medicare Advantage than in traditional Medicare because of all of these same cost-related barriers to care, coverage denials, prior authorizations. And then when we think about narrow networks are narrowing even more because there's a movement of hospital systems away from Medicare Advantage plans. And so the Medicare Advantage plans are actually finally starting to feel more of the impact of their practices because hospitals are saying this is actually not worth it to us anymore. The trouble with that is when these whole hospital systems and healthcare systems pull out of the network for an insurance plan, their patients are left with no access to care. And I'm seeing this play out every day.
Wow, that is so awful. These hospital systems are saying it's too much trouble to deal with Medicare Advantage plans because of these pre-authorizations. We're not able to treat patients the way we want, essentially. And so we're just going to not take Medicare Advantage patients anymore, which leaves the patients themselves with often nowhere to go.
Yes, absolutely. So far, I haven't heard of the hospital system saying we don't take any Medicare Advantage, but it'll be a huge Medicare Advantage provider like Aetna or Humana, but sort of one of the bigger names, United Health. When the hospital system drops that insurance, a lot of patients are carrying that Medicare Advantage insurance and they're suddenly left out of network.
So do you know what these patients are doing? Are they just driving farther or what are they doing?
Right now they're scrambling. Many of them are finding this out after open enrollment periods have ended. They are, stuck with a plan that they can no longer see their primary care or go to their specialty clinic. And I'm telling you, patients and providers are scrambling right now because a lot of that has happened right here just in the last few months, and it's going to continue through 2026 is what's projected. It actually ends up, the hospitals and the insurance companies talk to each other, and then my experience of it as a physician is a lot of times I'm finding out about it because my patient has received a letter from the hospital system that says, sorry, starting on this day, which might be a month later, might be 2 weeks later, we're no longer in network for your insurance. And that's it. And the patient who, it's hard enough for me to navigate our healthcare system when I need care. A lot of my patients really struggle with that. And they'll bring in the letter to me and say, I don't know what to do. It looks like I can't come here after December 15th or whatever date this is. And basically I'm on the phone, they're on the phone, calling the insurance, calling the hospital, trying to figure out what we do. It's a literal scramble.
Wow. It sounds like a real crisis that's happening.
Yeah.
And so how new is this trend of these Medicare Advantage plans with an insurance company being dropped?
Brenda, I should be able to give you a clearer answer on that, but I will say that somewhere in the last quarter, some big number of Medicare Advantage companies have been dropped by health systems, or the opposite, which is the health insurance companies have pulled out. Basically, it's a negotiation between the hospital and the health insurance company about whether they're going to work together and be in the same network. And I would have to look this up and tell you, but large numbers have gone their separate ways and left patients in the lurch. While I'm reading about this, I saw it playing out in my hospital with my patients. And when you say what happens to the patients, here are their options. And the hospital might tell them this is, well, you can maybe go seek care in this other place. And I'll tell you, for a lot of people who get their care in certain parts of our country, certain parts of our cities, they don't have a lot of options.
Wow, so scary. An editor's note, more than a dozen health systems, including the Minnesota-based Mayo Clinic and New York City-based Mount Sinai, are reportedly dropping or limiting Medicare Advantage plans starting in 2026 alone. So Medicare Advantage ads love to talk about dental, vision, and hearing benefits. The report calls many of these paper benefits. What happens when seniors actually try to use these paper benefits?
So you sign up for your supplemental benefit and you say, okay, great. I've just switched over to my Medicare Advantage plan, or I'm on Medicare Advantage. I'm going to go see the dentist because I need a root canal. First, they find out there's a waiting period. Can't go yet. You have to have the plan for this long. Then they go and they look to schedule an appointment and they find out how narrow the network is. And they may have to leave town altogether to find a provider in their network, or worse, not be able to find one. And again, this is an average. Like, obviously, some people are able to get their dental benefits with Medicare Advantage, but a lot of people get slapped with these issues. So the narrow network means they may actually end up having to see someone out of network, in which case they end up paying out of pocket anyway, and they don't actually get the benefit of the supplemental benefit. The other thing that happens is if they do see a provider who's in network, they have a deductible to pay. They have to hit that amount first. And then there's an annual cap on their benefits. So if their dental work costs $2,000, but their cap on benefits for the year is $1,000, they're also coming out of their pocket for that. And then there are exclusions, and as I've mentioned, waiting periods. So when you take all of those barriers to care into consideration, this has been studied. And the amount of money that Medicare Advantage plan with supplemental benefits saves over traditional Medicare plan for getting dental benefits, on average, it's $23 a year. And it's just ridiculous to think that you could have a plan that actually has supplemental benefits in Medicare Advantage and only save $23 over traditional Medicare, which has zero supplemental benefits. That's what we mean by paper benefit. It plays out for vision and hearing as well. I think it's about $20 on average is the savings across the country if you have supplemental benefits through Medicare Advantage versus traditional Medicare.
Right. So it's basically false advertising.
Yes, it is.
They play up the fact that they're offering these services, but then there's limited access to care, difficult to access. Yeah, that's actually a really important point that I hope listeners take away is don't be lured by these ads for dental, vision, and hearing benefits, because ultimately you're not going to benefit, and the disadvantages are so much greater in a Medicare Advantage plan than they would be in traditional Medicare with a Medigap policy.
Absolutely.
So we talk about narrow networks, but if somebody, let's say, God forbid, gets cancer and they want to go to their cancer center of choice, most often I would imagine they wouldn't be able to choose the best doctor, the best specialist they want to go to on a Medicare Advantage plan. Is that right?
Yeah, absolutely. You are 100% restricted to your plan network when you are in a Medicare Advantage plan, which is another striking difference from traditional Medicare. Most doctors, most hospitals, cancer centers accept traditional Medicare. And one of the reasons they do is they bill and they provide the care that they need, and they bill for it and they get reimbursed. And it's simpler. But many hospitals do not accept some of the Medicare Advantage plans, or they don't have a contract with them. So you may go see your best cancer specialist if you can afford to see them out of pocket, because your Medicare Advantage plan, if they're not in that network, is not going to cover your visits. And that's really devastating for people. And a lot of times when people sign up for a plan, if they did their research before and they were able to, even within these narrow ghost networks, find the hospital system that's on their plan, halfway through the year, they could learn in a letter, like some of my patients do, that, oh, sorry, starting next year, we don't take that insurance anymore. And what do you do when you're halfway through your fusions, when you're waiting for your surgery?
So if policymakers were truly serious about health equity, what is the first thing they should change about Medicare right now? And how would that immediately improve the lives of seniors of color?
So can I tell you 2 or 3 things they could do right now?
Yes.
They could institute a low cap on out-of-pocket expenses or limit out-of-pocket expenses completely. Traditional Medicare does not have an out-of-pocket maximum, and that's why there's so much financial exposure to people if they don't get Medigap. So that would change things significantly. A lot of people would choose traditional Medicare if there was a cap on costs. I am a part of Physicians for a National Health Program, and we advocate for single-payer healthcare. So what I'd like to see is zero out-of-pocket costs in traditional Medicare. But even if legislators just introduced a lower out-of-pocket maximum, like $1,000, they would put traditional Medicare on the same level with these Medicare Advantage plans, so that people do not go broke because they don't have a Medigap plan. A lot of Medicare Advantage plans advertise an out-of-pocket maximum, and that's attractive to people. So that's one thing. Introduce an out-of-pocket cap on health expenditures. The second thing that policymakers can do right away is, again, along the lines of leveling the playing field between traditional Medicare and Medicare Advantage, is provide the supplemental benefits. If traditional Medicare matched the supplemental benefits that are advertised and to some extent provided in Medicare Advantage, Advantage, that would go a very long way to evening the playing field, and a lot of people would choose to sign up for traditional Medicare. And people might hear that and think, oh, well, that's going to cost a lot of money. And the good news is there's a lot of money already in our system that's being used on Medicare Advantage overpayments. So something like $140 billion of overpayments are leaving CMS every year because of the fraud and tactics that the Medicare Advantage companies use to get more CMS dollars out of caring for patients who they upcode as sicker. If we were to rein in those overpayments, $140 billion a year could be redeployed and would absolutely cover putting a coverage cap on traditional Medicare spending, put supplemental benefits for everyone in traditional Medicare, so that we're not giving Medicare Advantage plans, which are private insurance companies who are profiting from healthcare, a leg up in this.
So, Dr. McIntosh, you're a longtime supporter of single-payer Medicare for all. How would such a system reduce inequities in healthcare? And can you give us some specific examples?
So, the point of a single payer healthcare system is there isn't any good insurance and bad insurance. Everyone is covered. No one is uninsured. Everyone is in. And that means if I break my leg today, I can go to this hospital and no one's asking me what my plan is to determine whether I can be admitted to this hospital or rehab on my leg, or whether I don't need a prior authorization for this or that. Traditional Medicare, it was meant to afford people the choice to go and get healthcare when they need it and not go bankrupt. And so unfortunately, what we have is a system of healthcare where if you have enough money or a lot of money, you can afford a certain type of healthcare. And if you don't, you cannot. And so we have these multi-tiered healthcare system, which leaves a lot of people without the access or the ability to make choices in their healthcare. And so a single payer plan says, we don't have this insurance company or that insurance company or one big insurance company that has several tiers. Everyone is in and nobody's out. And that is the first step to having an equitable system. But I would go a step farther and say that a single payer system where the delivery of care is also more standardized would make a huge difference, because we know that in our system here, if you go to this hospital versus that hospital, you may have a different choice or a different outcome. A single payer healthcare system helps us to deliver care in an equitable fashion to everyone. And no matter their cost, no matter their race or ethnicity, no matter the zip code they live in, there's no difference in what star rating their plan has versus another person. And so it's really the only answer we have.
Thank you, Dr. Belinda McIntosh. Do you love Code WACK? Keep us on the air with a tax-deductible donation at heal-ca.org/donate. Do you have a personal story you'd like to share about our WACK healthcare system? Contact us through our website at heal-ca.org. And don't forget to subscribe to Code WACK wherever you find your podcasts. Code WACK's powered by Heal California, uplifting the voices of those fighting for healthcare reform around the country. I'm Brenda Gazar.